Well, thank you, Carol, and thank you, Alex, for the introduction. You know, I will concede that even before Alex took out Dirty Harry and his Magnum 357, I was feeling a little bit outgunned, but I don't feel that way anymore. I do, in fact, feel lucky, and I'm going to tell you why as I go through my presentation here. These are my disclosures. So first off, let's discuss the elephant in the room. I'm the only person who doesn't have a PhD here, so I'm kind of obviously competing above my league. I'm dealing with people who are experts and very knowledgeable in ways that I am not. Trinity, his record speaks for himself. You can see his profile page here. 4.8 rating, prominent in both urologic oncology and our field, so really a top-notch researcher and clinician, a great friend. We have Alex, his profile is a little bit more understated, but clearly everyone who knows Alex knows his accomplishments, and he's fluent in 3 languages, which I think I knew at one point but forgot. I struggled to command 1. So really, I'm up here kind of underqualified, overmatched, in a situation where it's really going to be hard to make my case, but as I looked into the data more, I got even more concerned. Obviously, we know Botox is a big business. We use it a lot in urology and lots of other fields too. And really, if you read about this, what can't Botox make better? You use it in the vagina, you can get scrotox and smooth out your scrotum, you can treat your premature ejaculation with it, you can use Holtox for receptive anal sex. It makes that easier too, apparently. So if it can do all these different things, well, why can't it also cure ED? It's a panacea, so everyone should be on it, right? Well, I was worried, and again, knowing all these things and knowing who I was up against, I was initially concerned, but as a simple country urologist who's trying to make my way in the big city, I realized that they gave me this position because it's really the right position, and even I could handle this topic. So being a simple country urologist, as I articulated, I went to the guideline. What does the guideline on ED, our sort of Bible, if you will, of how to manage EDs tell us? Well, we have 5 standards of care. I have my own opinions about each of these, but they're all considered standards of care that patients can turn to seek their treatment for their ED. The guideline's not entirely just what we do now. It does invoke ideas that are out there and ideas that have merit and maybe are considerations for research and things that patients ask us about. What's interesting is that this guideline was published some years ago, but it didn't even bother to make mention of Botox. Obviously it's a topic that was of such great importance. Dr. Pashczak lets us know how great it is. Well, why didn't we mention it in that guideline? Fair question. The AUA guidelines are pretty rigorous, and if there was something out there, you'd expect them to bring it to our attention. I did consider that in Europe, they tend to have more liberal guidelines. There's a bit more willingness to take on things, and they update their guidelines more frequently than ours. It was mentioned there, but what they concluded was what we have right here, that you really can't use it in clinical practice yet, nor should you. Sure, there's some evidence, but is it clinical ready? Not at all. Not something we want to turn to right now. So having established, again, well, the guidelines aren't saying we should do this, I decided it was time for me to look at some of the primary literature. And again, to simplify things, I looked at the most recent meta-analysis from 2022. I turned up some of the papers that Alex showed us too, and what was interesting was that a few of them weren't published, that this data was derived from. Several of them were case series rather than randomized controlled trials, and there was a large range of doses. As you saw, and as we saw reported, there are some positive outcomes, some statistically significant results of p less than 0.05. However, I would submit to you that patients don't really think about their PSV or their shim score when they're having sex, do they? They're thinking about, can I have sex or not? Is it working or not? And of these various metrics that were highlighted in this meta-analysis, the only one that really comes down to brass tacks is the erection hardness score. Is the penis hard enough to have intercourse? And there was a modest benefit. Again, statistically significant, clinically harder to say because it depends partly on where you start. So the conclusion of this meta-analysis, once again, articulating the case that this is not ready for prime time, not something that we should be using in our clinical practices at this moment. So since that 2022 update, there have been some additional publications. One of the non-published series that was in that report was actually published, and I was able to read it. And again, you see here, this is a cohort of patients with pretty severe ED. Very low shim scores, and the SEP scores were also low. Again, for recollection here, SEP 2 is can you achieve an erection rigid enough to achieve penetration, and SEP 3 is can you maintain your erection to the conclusion of intercourse or climax. And what's interesting here is these are 12-week data, looking at what's happening to these patients 12 weeks after their Botox shot. Yes, there was once again a statistically significant improvement in that SEP 2, could you get an erection hard enough to penetrate, but if you look at SEP 3, did you maintain that erection? So yes, you could argue these people are having sex, but are they able to reach climax, which for most men is kind of the goal? It was about 6%. So not exactly a robust outcome, and certainly something that I would say it does not really suggest that this is a treatment that's making a major impact on the quality of life of our patients. Francois Guilleneau phenomenal researcher, great pioneer, member of our field, again, updated his series as well, looking at patients who decided to go for additional treatments. And certainly it's a large population of people who are being treated with Botox in his clinic. A minority of them are actually seeking out second shots. And we know that Botox is not forever. So obviously, if these people are not seeking out second shots, we don't know exactly why they're not, but I would have to contend that many of those people who are not bothering with the second shot are doing it because the first one didn't work for them either. So we have at this point, from these studies that I've highlighted, 531 patients total. And these are two highly reputable, well-renowned centers, Hussein Ghanim and Francois Giono. Many of these patients, however, not representing genuine randomized controlled trials. I want to draw a comparison here to what we have in Shockwave, which I think is perhaps a more compelling and interesting research topic and potentially more promising way forward. These are the data we have on Shockwave right now from, again, a relatively recent meta-analysis, 16 randomized controlled trials, 11 countries, over 1,000 patients, outcomes probably similar to or better than what we're seeing with Botox. And despite that, even then, with all these much more robust bodies of data behind it, shockwave therapy is still deemed experimental by the AUA and only selectively endorsed by EAU guidelines. So we can conclude from this, and we haven't even talked about some of the logistical and cost issues associated here, Botox is not cheap. And ultimately, we're talking about this. And I think when it comes down to brass tacks and what patients actually want, a nice shim score elevation, your peak systolic velocity is higher, that's all well and good. But in the end, if what you're talking about is offering someone a slightly less limp penis that is still not able to help them reach climax, you're not really talking about a winning treatment here, especially when the price tag is as it is. So for this reason, I think it's pretty obvious that Botox, as exciting as it is, as compelling as it is not at this time an appropriate therapy for ED. With that, I thank you all for your attention.